that today we've already blown a stereotype that people who are in high levels are people who've all got it together and have perfect lives. Because I want you to know that all of us are in the same boat and can experience the same things. And actually, sometimes those difficult things are the things that drive us. And thank you so much, just the courage already for people to share. It's inspiring to me already, and I think already emotional, because this is real things, isn't it? And today, I think we are being really brave, actually, because we're talking about two really difficult subjects. But we decided as a kind of a team that we needed to talk about these things, even though it's sometimes difficult to hear. But it's only by talking about them and by being real about them and actually knowing how many of us are affected in different ways that we address these things. You can see, I think I've introduced myself, but I think now is probably a good time to go into my next slide. Which is just a moment of reflection. As I say, we are talking about some hard things today, and we are going to be affected by the stories that we hear. And I think in some ways that's hard, but it's also a good thing, because it will hit home. And I think the positive things is these things are really already motivating us. And I want to say a big thank you to you in this room, because I know, as Jeanie has already mentioned, and David, there is many people in this room who are already doing tremendous things. And I wanted just to say that already, and doing tremendous things because we care. And so I just wanted to say that we're here, isn't it? And the people here are here for that reason. We know the things we're talking about data, but we're talking about real lives. And we need to develop these strategies. And so just remember today we are to take care of ourselves. So if you do need a moment out, please feel free to take that and to reflect and to talk. There's people around you on your table as well, and we'll have time to talk and break out together as well. And what I'm going to go through now is kind of going through some of the data, and we're going to talk a little bit about how this came to our attention really in Cheshire and Merseyside and why we decided to focus on this and what the data was telling us. We're going to talk about our real-time surveillance, and we're also going to be talking about our strategy. And I was reflecting that a year today, this conference was delayed because sadly today is the anniversary of the Queen's death as well, and so we all had to rejig the conference in honour and respect of that. So that's what we're going to be looking at in this presentation now. So this first slide here is showing you the data for Cheshire and Merseyside from 2003 to 2021. You'll know that with data around suicide that there's often a delay in the data getting published for quite a number of years. And you can actually see this here because the latest available data is still 2001. We don't have formally published data for 2002 as yet. It should be published any day now, but it's been delayed. But you can see that actually this is one of the reasons why we needed to have a data system ourselves. What you can see in this graph, and actually some of these figures perhaps don't show, but actually in 2014, in particular, Cheshire and Merseyside had a higher level of suicide, sadly, than the national average. And then you can see that it was around that time that we really started a real concerted collective effort to try and bring down our suicide rates. And actually, you might remember from last year, those of you who are here, that we did book the trend for quite a number of years. And actually, we were coming down where other areas were going up. So what we did, we feel made a difference. It's always hard to prove it, but the data showed that we were definitely doing something right in that way. Although our energy is to always do more because we wanted to get it even lower. What's interesting, perhaps, is also the pandemic effect on this. And I'll look at some kind of Cheshire Merseyside data. But it seems, I think, during the pandemic, there was a bit of a feeling, particularly in the early parts of the pandemic, that we were in this together. And actually, there was less suicides, you'll see. But then after the pandemic, and perhaps because COVID kept coming again and there was other pressures, you can see that 2021 wasn't a good year for us in Cheshire and Merseyside, and indeed nationally as well. We think that some of the data is similar, sadly. This is showing you the difference now across Cheshire and Merseyside, so from 2019, and this is our real-time surveillance data. So this is a little bit different, the numbers are a little bit different because we include suspected suicides in here as well. And so we have data until in 2023, so this is one of the things that's really powerful for us because we're able to see the data fairly up to date. And I think this is up to the end of August, this data that we have for 23. You can see some differences in trends here. So, and there is, we think, a bit of a pandemic effect. If you look at Merseyside, 2021, there was kind of an increase. And some of you will know that in Merseyside, in 21, we had really high levels of COVID. And also Merseyside was the place that was probably in one form of regulation or restriction longer than most other areas. And so we felt that that is possibly what increased the spike there. And then what we found is in early 22, it was Cheshire that had some of the highest rates of COVID in the country. So those early kind of January, February of that year, it was Cheshire who was in the headlines for the wrong reasons in terms of COVID. And so you can see that in 22, there was an increase in suicides. And we think it's possible that it was that kind of COVID effect on that. And then you can see kind of for the 2023 data to date, for Cheshire, for Cheshire, if you think about comparatively that we've still not the end of the year, that figure looks like it's still higher, and we're going slightly the wrong way in Cheshire, where in Merseyside perhaps coming down a little bit, but it's difficult to tell. But that's the indications that we're looking at. I'm going to show you just another little bit in terms of our data. I don't know if all of you will be able to see this, so I'll explain it. But we're able to split the data down in much more detail than this. I'm just going to be sharing with you the age and gender. But actually in our real-time surveillance data, we get an awful lot more information, kind of self-harm data, for example, visits to primary and secondary care, mental health support, all sorts of different circumstances, people's jobs, different family circumstances. So we get an awful lot of data. But I just wanted to kind of show you here the age and gender split. And again, the first chart is looking at male and female from 2019 to 23. Typically, we follow the national trend here, which is that men are still around 75% of our suicides. And so you'll know that for a number of years, we've had a real focus on supporting men, and particularly around talking and men reaching out for support. And we've had lots of community work and some successes, really, in getting funding and doing some real projects to champion men's mental health as well. But this year we are slightly seeing a slightly worrying trend in one sense, that female suicides seem to be a higher proportion of our data at the moment. So we're actually around 35% female suicides, which is unusual. Now, there's a little bit of the male suicide staying the same or reducing slightly, but a concern for us that female suicide is maybe increasing. And we're not yet sure if that's a real trend or not, what the cause of that is, but that's something that we are monitoring. So this is one of the things that this kind of data does. It gives us an opportunity to pick things up and to start to monitor them, to monitor where they are, what age groups, and all of those kind of things. The next slide is looking at male and female, and this is looking at the life course. And again, just in terms of some of the figures, the little dash less than 5, is that what that means? So, but you can see some differences in age across this. I think there's a few things I'd say. We've had less than 5 in male and female of 10 to 19s, but it saddens me to think that we have 10 to 19s on this chart, and we have had some teenage suicides. So that shows us we really need to be thinking about families, really important, and schools, absolutely. And you can see, even in the 20 to 29-year-olds, we're already seeing quite high levels of suicide. And we always kind of think about kind of midlife, and you can see, particularly with males, that kind of, particularly that 50 to 59 age group, and either side, the 40s to 60s. So you can see the midlife, but we are kind of seeing that worrying for both male and female in younger age groups as well. So that in some ways we're feeling this is less of a midlife, but actually, sadly, right the way from teens. And then there are differences each year, but we are also looking at our rates of suicide, particularly in the over 80s. And I think there's some anxiety, again, around the cost of living, people feeling a burden, perhaps people not getting the health and social care that they need. And so we're really keeping an eye on kind of suicide in the older age groups as well. And I think, we've been living through a cost of living crisis, haven't we? Cost of living rises. And so we've been really feeling we needed to keep the energy and the focus on suicide prevention and mental health. And of course, tackling the causes and making sure that people are getting help and support and just flagging this. And I think we're concerned that actually the cost of living rises may well be impacting this, and tensions within families as well. When there's financial pressures as well, that doesn't help those family relationships. And so it's something we're keeping an eye on and really wanting to keep our focus. So you'll know that we relaunched our strategy. We've had a number of strategies, and so we updated our strategy in 2022, and we launched it here last year. Again, we've got some speakers people are speaking from lived experience, but our lived experience network were really phenomenal in supporting us to write this strategy, both in kind of having focus groups and artwork, really engaging. And I know last year, some of our people with lived experience were really brave in sharing their stories and the stories of their family members. The things that we were focusing on in our strategy, so we've got kind of 4 strands, if you like. So men, I've already mentioned. Children and young people, so you can see why, just in terms of families and the impact. Self-harm, for 2 reasons, is that there's a really high link, unfortunately, with self-harm and suicide, and particularly severe levels of self-harm. And sadly, in Cheshire and Merseyside, we have some really high levels and pockets of really high levels of self-harm. So that is a real focus for us. And the inequalities, I didn't show the slide here, but actually there's a real obvious inequalities link around suicide, particularly for men, less so for women, interestingly enough, but for men there is a real inequalities angles. And as we've looked at the data, domestic abuse is apparent in all of these groups and all of those in terms of self-harm risk factor, inequalities, children, the young people. Jeanie very bravely talked about that, men as well, and the impacts and the families. So we began to see some of the data through our real-time surveillance around domestic abuse. And this is one of the things that's in our strategy, because we want to be both evidence-led and data-driven. Because we want to make sure we're going to be doing the things that make the biggest difference to the people we need to make the biggest difference to. And so our real-time surveillance is one of those key data sources. And some of you will know, and I know we've got some of our champions from the local authorities here who are part of groups, and I know Neil and the team meet and actually look at the data in detail in local areas to understand the impacts and what's happening locally as well as a region. I think the other thing that's a real passion of us and is in our strategy and came out really strongly, and I hope already has come out today, is tackling stigma and discrimination. And sometimes all of us can have prejudice from the way we've been brought up, from the society we've been in, or we're in, the people we talk to, the people around us. And we want to be tackling stigma and discrimination in every way, even in the way that we set up services. Sometimes, unfortunately, we set up things in a way that can actually put barriers up. So we need to be thinking Are we putting any unnecessary barriers up, and can we bring those down? And then we're going to talk a bit about some of those discriminating behaviours and why they're there. This is some of the data that we have. So 22 of the suspected suicides between September 21 and December 22 had a link to domestic abuse. 22%. Of those, of 180 cases, we had 27 where there was a suspected domestic abuse. We had victims and perpetrators through this. Really, you can see the perpetrators are probably the highest, but bear in mind some of those perpetrators are also victims in one way or another as well. And we also had somebody witnessing abuse as well. So we know that this is across. Also, when we looked at this, we had majority male. That might surprise you, and one female. So actually, in terms of this suicide cohort, it was predominantly male. The self-harm data might well be quite different to that. Of the cases that we looked at as well, the age range was that 20 to 44, and the 8% were ranged 45 to 64. So you can see it's kind of affecting a younger cohort than the overall suicide data. I won't go into the male and female so much. I think the other thing to bear in mind is the figures, underlying figures, we think are probably much higher than this. And this is because the process is reliant on what's recorded by the police officer taking this, and they may not have all of that background information. So we actually think that 22% is a real underestimate. I just wanted to flag that to you. And also it shows that this is something we're still needing to get better on in terms of everybody acknowledging this, asking the questions, recording it, because it's not something that's always being picked up. So that's maybe something already just to flag, just thinking about making sure that we're making the link and we're recording this information. I think this is a bit that saddens us, and I know our keynote speakers are going to be talking more about this. But in terms of domestic homicide reviews, already the data indicates that 50% of those reviews are related to a suicide. So as many people die as kind of be murdered or whatever as suicide. And yet traditionally we haven't looked at suicide and that link, if that makes sense. So actually there's a lot of learning, sadly, from the domestic homicide reviews. The northwest of England was slightly lower at the moment at 36.8%, but that does vary. But just to say that to you, so this is why we've got that bit of a dual focus in the learning today. I did want to take a little bit to kind of think about some of the stigma that we talked about earlier and why that might be there. These are some of the things that, we're talking about evidence and research. These are some of the themes that are picked out in the research. And I think, some of the speakers already have highlighted that victims feel shame, embarrassment, fear of being labelled, particularly parents, when you're a parent. And I think, people talked about that very bravely, that there's a fear of being labelled. Also that even participants in studies, still there is a stigma that's in society that we put blame on victims. Why didn't you leave? Why didn't you do this? Why didn't you see this? And so we have that negative that we need to come away from as well. There's also kind of myths around that. People don't understand when you've been in a situation for a long time, and the things that have been said to you and the coercion and other things that go in there. So there's myths that we have to address. We talked about children as well, and unfortunately, and I know Jeanie talked about this, the long impacts on children. I think both David and Jeanie really talked about your childhood and the impacts that can have on what children witness. And also we talked about the stigma that offenders feel as well. that people feel as if once they've done something that there's no way back for them, and that as a society that we throw them away. And that we know that perception of how people feel affects how they respond once they're released from prison. Despite anything else, how they feel, that perception affects how they do and how they integrate into society. There's more as well. I know we talked about past and committed. You know, in this country it used to be a crime to take your life by suicide. We talked about in churches as well that it was a sin, it's perceived as a sin. Talking about suicide and talking about suicidal thoughts, and again, bravery, people talking about actually you need to talk about this and get help and support. And also, sadly, we have experiences and we've heard of people who've sought help and then have been discriminated against for various reasons. Sometimes they're put in the too hard box. You're drinking. You know, we had a really sad case of somebody who was drinking and was reporting that they'd been abused as well, but people focused on the drink problem rather than actually what was happening around them. And also sometimes when people have self-harmed, people have a perception of, well, you did that to yourself, isn't that terrible? But people have that kind of perception around self-harm, and we really have to tackle that. And our attitude to people who've committed crimes. What's our right response? What's our right attitude? How do we support people to, you know, even just in reducing harm for others as well? You know, I think probably the worst outcome for a family member or a victim is if a perpetrator takes their life as well. You know, that has massive impact. So we need to be thinking around attitudes. So these are two traumas that can collide together, and therefore the impacts are like a ripple effect. People can feel isolated and hopeless, lonely, and these are the things that we need to tackle. Perpetrators can quite often have mental health issues themselves, been through difficult things, suicidal thoughts, and they're particularly at risk when they're no longer in control of the situation. So, for example, once it gets known about what's happened, once they're removed from the situation, maybe they're distant from their family, that's when their biggest suicide risk is. So we know that both victims and perpetrators are at risk of suicide, and it's always devastating, always. So there is a growing body of reality out there around the link between the domestic abuse and suicide. We need to kind of put domestic abuse as a priority within suicide prevention, and this is coming out not only locally but nationally as well. However, what works has been really hard to identify, and we've looked at other areas and really struggled to find a strategy. So we might be doing some things today that no other area has done, and coming forward for things, so we may well be taking a national lead here. And also, just to mention, there's a new ruling around Kelly Sutton case of unlawful killing as well, which means that there will be more justice for those who die by suicide. However, we need to be more preventative in our approach to prevent these situations. And I think that's the message I want us to go away with. How do we stop getting there in the first place? How do we prevent these things? What actions do we need to take to stop this happening?